You know what I've heard? I've heard that people, lots and lots of the finest people, are saying that they just can't get enough of the interviews we did with EMS researchers in the last episode from NAEMSP in San Diego. Just like Billy Idol, I'm hearing what they really want is more, more, more. Well, to further mix my musical metaphors, who am I to disagree? Stay tuned for more great research interviews.
What is a lighthouse? It is a tower with a bright light at the top, located at an important or dangerous place. The main purpose of a lighthouse is to serve as a navigational aid and to warn of dangerous areas. Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome to another episode of the EMS Lighthouse Project podcast. In this episode, we have 3 more great interviews. We're going to start off with Dr. Brian Miller from MedStar in Fort Worth, Texas, talking about his concept of MCD Walk. Then we're going to switch over to San Antonio and talk to Dr. Frances McClure about the impact that EMS leaders can have on their medics' decision to get vaccinated against COVID. And then we're going to wrap up with a great talk with Dr. Jim Menegazzi from the University of Pittsburgh about work he and his medical student have been doing on sodium bicarbonate in cardiac arrest. Let's hit it off with Dr. Miller.
Dr. Miller.
Hey, how are you doing?
I am doing well. Thank you so much for talking to us.
Oh, absolutely.
Man, I was walking past this and I see this concept of MCD Walk. Like, I've got to talk to Brian. Tell me what the hell MCD Walk is and what your paper is looking at.
First off, I got to just acknowledge our clinical quality team. It really was the ones that spearheaded this. Kerby Johnson and Bob Gleason and also our medical director Veer have all been involved on this. And so it's really been a collaborative effort. And
cool.
Really, they're the ones that did the real stuff. And so what MCD Walk is actually a device migration where as you start the device and it continues through its CPR cycles, it will actually start moving on the chest out of the optimal position.
So MCD in this case is mechanical compression device.
CPR device is the
Lucas.
brand agnostic name in some way. There are absolutely different devices. You obviously have the compression bands as well. We're all a piston-driven type system at some level.
Okay. So perfect. What did you tell me? What you looked at, how you looked at it, how you defined it, and what you found?
Yeah, and so right at the kind of peak of COVID, a lot of our agencies using the funds that were out there, and in the force protection type mentality, we had an explosion of MCDs in our system. Previously, we basically had on our supervisor vehicles, and then with COVID, it became on almost all the frontline apparatus. So now about 80% of our CPRs are run with a mechanical CPR device in place. And so we already did quality assurance on every one of our cardiac arrests, including editing the monitor files and hitting our device metrics and all that. And so
you're talking about what you're doing before you implement it.
Yeah, y'all have been doing that. So this was all just right there,
and
then we continue to look at then the mechanical CPR placements and the time when we can measure basically that CPR pause when they were implemented, and then also what we noticed is a pattern starting to develop where you could actually see a gradual decrease in the depth of compressions by being performed by the device. And so we saw that just over a hair of a year, about 13, 14 months was the period that we looked at there. And so we started to really kind of hone in on this issue and then actually start implementing some quality improvement cycles to improve that.
So you said a decrease in the quality compressions, and just to be clear, you're talking about not a decrease over the year, you're talking about a decrease in quality compressions over that code.
Right, exactly. In the individual case, we would see that progressive decrease. We'd have our AHA metrics where we were targeting the depth, and then you would actually see that fall down. And one of the other things that we would see is that we would see a drop in what it thought was actually no compressions being done. It thought it was a ROSC period because some of these depths were so low that it had fallen below the 1 inch mark, and so it thought there were no compressions even being done during some of these.
Yeah. So you're talking about this decrease in compression depth. How did you identify that?
Right, and so we have our monitors puck, where it actually measures the CPR quality and the depth and release velocity, and then you have your standard pad placement. We do an AP pad placement, anterior posterior, with the puck centered in the chest, where you would otherwise think the puck would be, or the piston being down.
Yep.
So.
And so this is what you're seeing, huh?
Right, and so here you can see that the device was placed, and it starts out with basically great compressions. You got the steady rate as you would expect, and then you're perfectly in depth. And then as you go through the code, this is a 5-minute mark and a 5-minute mark here. And so over this period, you start to see this kind of gradual decrease in depth into that drop into the shallow range. So this is about 1 inch right here, and so you got compressions that are down into to not even registering or even under an inch.
Awesome. So, and how often was this happening?
So, and basically we had just over 1,100 arrests over this period, and so we had about 68% of them where there was no walk or no migration. But then in about 31.9, almost 32%, we were actually seeing some walk. And so at some level, the walk probably is going to be expected in some way. You are going to see some migration of the device. However, what we really wanted to focus in on is then the recognition of the walk and then the correction of it as well.
And is that so you mentioned two things. You said we found data, we did quality improvement efforts to address it. The corrected walk, though, you're doing this on a code.
Right, so that's in real time.
How were you, and by the way, we've seen this exact same thing.
Yeah.
How were you telling your medics to watch for this and then to correct it?
Right. Our clinical quality team, when they really zeroed in on this, they started to go and actually interview our providers that were actually placing these devices. And so they made some cardiac arrest scenes, looked at how these were being performed. And one of the first things is, making sure that the manufacturer recommendations are there. The detachable neck strap is one of those things that often is discarded and forgotten because it got nasty or dirty or just lost. And so that was one of the things we initially emphasized right off the bat, was get that neck strap on to secure that device in some way. And then the second part of that is that we have real-time CPR quality on the monitor, and so having a dedicated person watching that CPR quality metric and make sure the diamond is full there, and if you start seeing that, you need to be checking your device. The other parts was that we had basically a Sharpie start to be marked where you actually have your compression at there. And so that way you knew it was going to walk. And then the final thing is basically the intervention of having a mechanical CPR kind of overwatch or a babysitter in some way. So a provider who's actually actively and has a dedicated role in maintaining that placement and watching that.
So one of the fascinating things about this, and I'm sure Stryker is going to come strike me down for saying this, one of the justifications for doing this is you free up manpower.
Right.
But now you have to expend more manpower to make sure the device that frees up the manpower is not doing something wrong.
Absolutely. And so it's like many of the interventions we do out there. It's just going to be easy, it's foolproof, and just like anything, there's a risk and benefit to it. You obviously free up hands, but you still have to have dedicated watch over these devices because there is a risk and benefit. And then of course, as others have noted, the actual placement at the beginning also very much matters.
So where do you go with this next? What's your next thing to find out about this walk?
And so we started the quality improvement cycles. We started out, in the typical fashion, very small, and so we hit some of our smaller suburban departments. And so we started out with some more pilot stations, our larger departments, and now it's basically working out to a system-wide. A, on the awareness standpoint, and B, then what are your correction tools out there? And so we're getting out to the full system in that way. And then this is what, for our system, we're starting to monitor is we're trying to get to the point where we have no unrecognized walk, that you recognize the walk and correct it or minimize that number as much as possible. So the small stations that we have done this on, one of them has actually done a phenomenal job and it has had zero walk in about 20 of the cases now.
Have you done anything to compare, say, outcome between this group and this group?
Don't believe we've gotten that deep into it yet, but from a system-wide standpoint, we're actively watching that data there. And, it's a multifactorial thing with COVID and everything going on at the same time. And so really parsing that stuff out has been difficult.
I think, so what you're finding here is definitely consistent with the ultrasound literature, with the TEEs. And what they're finding is as this migrates up, it's now compressing not the ventricles, but the aorta.
Right.
And no doubt that's actually decreasing perfusion. And maybe things like this, combined with things like prolonged pauses to apply the device, that may be the explanation for why the randomized control trials with these devices never showed any benefit.
Yeah, and so it's not that up-down, it's every axis really. It's the X, Y, and Z axis that we have to watch, because you'll see lean and all those things too, but
so,
great points.
Brian, what is, you're going to tweet out this study. What is your tweetable result? What's the one takeaway in 140 characters? I'll give you 280. It's
First off, no MCD walk is a thing, and if you're not looking for it, it's more than likely happening at your agency level, and if you're not watching for it in some way. I think we've all had some experience with movement of the device, and know that that is a clinically meaningful thing in some way, that you are actively seeing a decrease in your performance of that. And then taking your steps to use it properly and avoiding those things along the way.
Perfect. Brian, thank you very much.
Thank you so much.
Outstanding, man. Thank you.
I don't know about y'all, but I thought that was great information from Dr. Miller and his colleagues about a concept that all of us using any type of piston compression device probably ought to be paying attention to. Great work, Dr. Miller. Well, let's move now to San Antonio and talk to EMS fellow Dr. Sarah Frances McClure on a really important topic, and that is how the attitudes and involvement of EMS leaders can impact the decision of medics to get vaccinated.
Dr. Sarah Frances McClure, tell me what you are doing in San Antonio.
I am an EMS fellow with UT Health in San Antonio.
Not a Williamson County paramedic.
I am not a Williamson County paramedic.
Anymore.
Yeah, I still have that identity in the past.
I still feel the same way. Hey, so as part of your fellowship, you did a research project. Tell me what you did.
I did. I was looking to see if EMS leadership can positively influence the COVID vaccination decisions among EMS providers.
Awesome. And tell me what your methods were and what you found.
So we had a 23-question survey. It was an anonymous survey sent out across the U.S. To look at various factors that might influence the decision of an EMS provider.
Okay.
There were 2 questions that really kind of harped on EMS leadership's influence in that decision. The first one is, how present is your EMS leadership? And the answer choices were actively engaged, weekly meetings, monthly meetings, an occasional email, or who is my medical director?
That was the milk carton question?
Yeah, exactly.
Okay.
And then the second one is, what sources did you use to determine to make your decision of getting vaccinated or not?
So when you're defining leadership, who are you defining leadership as?
So leadership was defined as a medical director or an administrator.
A medical director or an administrator. Okay. So we're looking for, you ask questions about how likely are you to get vaccinated, and you ask questions about how engaged your medical director is.
Yes.
And then you correlate it.
Yes.
What'd you find?
So what we found was, if you had at least monthly meetings, you were more likely to have EMS providers to be vaccinated.
Interesting.
And we did that by bucketing the responses between active, and we defined active as at least monthly meetings, and then infrequent was occasional email or who is my medical director.
All right. So I like it. What we're seeing here, and I like this because, as medical directors, we like to think we can influence behavior. It kind of looks to me like we can influence behavior here. So, Dr. McClure, tell me, you looked at the influence of medical director leadership. How about other things? It looks like you looked at political opinions of
We looked at a lot of different things. Another was the sources of information contributing to the vaccination decision. We listed a bunch of different sources, and then we had an other box as well.
Darker orange here is you're more likely to be unvaccinated, and if you this is deeply distressing to me, since we're on a podcast right now, that if you got most of your information from a podcast, you were less likely to get vaccinated.
That's right.
I'm assuming people are listening. I would love to find out which podcast, but I'm guessing this would be the EMS Lighthouse Project podcast, and this would be Joe Rogan.
Yes, that would be the guess. We're not sure. I didn't ask specifics.
All right. In political view, what did you find there?
Political view, you're more likely to be vaccinated if you're if you place yourself on the more liberal scale, and less likely to be vaccinated in the most conservative scale.
And it seems like this is hardcore liberal, hardcore conservative?
Yes.
Okay. So it looks like a dose-response relationship, which might get us back to where do you get your source of news?
Right.
All right. Perfect. So what is your takeaway from this?
So my takeaway is that active EMS leadership can influence the health of a department and a decision in the department. And then I would like to know what active leadership means. So future research would be, what does active leadership really mean? We didn't define that. And where else can we influence the decisions as EMS leaders?
Awesome. I think this is important work because I do like to think medical directors make a difference in general, but boy, in the middle of a pandemic, when we have a tool that can help keep our people safe, that's our number one job. And if we can do something to get maybe more people vaccinated, I think it's really important. So just show the hell up at work and let your people see it.
Yeah.
Awesome.
Thank you.
Nice work. Thank you.
That was great information. And you know what? I think all EMS leaders, whether you're a medical director or a system director, a supervisor, or whether you are one of those unofficial leaders that people in your system look to, probably particularly those unofficial leaders, I think it is really important that we understand the impact we can have on those folks we work with. Now, although Dr. McClure and her colleagues were just looking at the association of that involvement with COVID vaccines, I am guessing that the same association would be true with other healthcare-related decisions, whether it's exercise or healthy living or other public health issues. I think we need to be mindful of the impact we have on those we work with. Well, let's wrap up now with Dr. Menegazzi from the University of Pittsburgh Medical School. Great information about something that I thought, in the words of Stone Temple pilots, was dead and bloated. And I'm talking about bicarb in cardiac arrest.
Dr. Menegazzi, this is a pleasure to have you on the podcast. Before we even talk about your students' work here, I want to thank you for the incredible contributions you've had to emergency medicine, to emergency medical services. You just retired as the editor-in-chief of pre-hospital emergency care. Thank you so much for that amazing work. You've done wonders for the profession.
It's been an honor and a privilege to serve NAEMSP, which is an association that I'm proud to be a member of and have been for over 30 years. And it just seemed like it was time to pass the torch, and Dave Cohn will do a tremendous job with the journal.
Awesome. Well, thank you so much. And by the way, I love your Elk Foundation shirt there. Yeah. This is amazing. It looks great.
I'm a longtime member. I don't hunt elk. I've never hunted elk, but they're one of the major conservation groups that I support. And I hope to get to Colorado or Idaho someday.
Yep.
From Pennsylvania to give it a go.
It's gorgeous. I have been on one elk hunt in my life and loved it. Best hunt of my life. It was wonderful. Well, I'll tell you what, let's, before we talk about this paper, I kind of want to announce my bias, which is that outside of some specific areas, TCAs and hyperkalemia, I'm not sure that bicarb has a role in cardiac arrest. So as I was walking past and saw this, I'm like, well, that's not what this says. Maybe I need to take a second look at this. So can you tell me what y'all found here?
Yeah, first, I think your bias is justified. When you study the literature on bicarb use and out-of-hospital cardiac arrest, it's very mixed. Sometimes it looks beneficial, sometimes it looks detrimental. So your concern is reasonable and justified. So I'm on the opposite side of the fence. I believe we should be using bicarb, and in my laboratory, I use it all the time. And I give it first. I give it before epinephrine because I believe it will improve the effectiveness of epinephrine. So that's one of the reasons. And when you've had prolonged cardiac arrest, and your starting pH is 6.9, that's not a good environment to give the other drug. So that's my bias.
So is your complete tangent here, but is your bias that lack, the pH is making epinephrine ineffective in cardiac arrest?
Absolutely.
Interesting.
Yes.
So that's your explanation for, say, the Paramedic 2 trial, that maybe if we had done bicarb first.
Early and first.
Interesting.
Yeah. But anyway, so I'm working with a medical student from the University of Pittsburgh, Sarah Niederberger, and we sought to query the ESO database, which of course is based in Austin, Texas.
Yep.
We worked directly with Renly Crow, Dr. Renly Crow, and it was just a terrific experience. So we have these big data, and we can start to ask these questions. And when you have numbers this big, you can manipulate the data and do propensity score matching. You can do multiple variable logistic regression, trying to control for all the variables that might influence the answer.
Right.
And so what we see is the answer actually changes dramatically when you do just a raw analysis and then you adjust for everything else. You get a very different answer. We presented yesterday a paper on just overall EMS treated out-of-hospital cardiac arrest and bicarb use.
Okay.
This particular study is EMS Witnessed bicarb use.
Okay.
And as you know, EMS Witnessed cardiac arrest is about 10% of all cases.
Yeah, and more than likely a whole different beast than
A
unwitnessed.
whole different beast.
So you took the ESO data set,
Yeah.
and are you just looking, obviously this is retrospective, so you can't
Yeah.
control for anything, but are you just separating into two buckets, those who got bicarb and those who didn't?
That's correct.
Okay.
And then after that, we're adjusting for all these variables that could influence the answer.
All the usual
And
suspects.
that's the most important, yes.
Okay.
Witness or not witness, first rhythm, bystander CPR, etc.
Okay. And then what was your primary outcome here?
So the primary outcome was, well, there were two. We were most interested in ROSC and survival, ROSC and survival.
And survival, so the ESO data set is unique in that it has some outcomes. Was that the data you're using for survival?
We were looking at survival to hospital discharge.
Discharge, okay,
Yeah.
based on the HDE data.
Yes, correct.
So did you limit your search just to those patients that had cardiac arrest and outcome data?
So we started out with all out-of-hospital cardiac arrest, was 148,000. And then we skewered that down to those that were EMS witnessed.
Right.
The other study was presented yesterday with all comers. And then we controlled for all the variables that we know can influence the answer.
Okay.
And once we did that, the answer shifted fairly dramatically.
So let's see, what are we're seeing here? This is the distribution of arrest. Oddly, a little higher VFib than I've been seeing lately.
Yes, that's true, but again, these were people that had a pulse and were talking
Well, this is
when
true,
EMS
yeah.
got arrived.
Yeah.
So,
And they probably were calling because they had chest pain and then
and they were
arrested.
circling the drain probably,
Okay.
yeah.
All right, and this is the folks who survived with bicarb versus the control.
Well, that's return of spontaneous
ROSC,
circulation,
ROSC.
yes.
So it looks higher in the control group than the
Yes,
bicarb group.
right.
Okay, my bias likes that. Oh wait, this is flipped. So you're
Yeah, it's actually much better
yeah.
without bicarb
Okay.
until we control for all these other variables.
Well, because I'm liking this table.
Yeah, yeah.
So tell me about this table. What do
Okay,
you
so
find
now
in here?
this is really the take-home message. So in this table now, we've adjusted for all these other variables that are confounders,
Yep.
known confounders. And what we find is overall, survival was better. It was much better in patients with VT and VF as an initial rhythm.
Okay.
That's almost counterintuitive because you think they're better off because they have a shockable rhythm right off the bat. Looking like maybe with asystole and maybe with PEA, but not really.
Yeah, your confidence interval is way across one.
Yeah.
Okay. Nice. So what you found here is that after adjustments for the things we should appropriately adjust for, in EMS witnessed arrest, bicarb actually helps.
Yes.
You presented your paper on all comers, so I missed that. What did you find there?
Okay, so that was abstract number 32, if somebody wants to go look. What we found there was, again, overall survival was improved with bicarb use.
Interesting.
And it looked like in that giant cohort of all comers, the biggest group that benefited the most was those who had asystole as a first rhythm. But I think one thing that we need to stress is the early administration, just like with early epi, is what's important, I think.
So maybe we ought to go back to the pre-86 ACLS. All right.
What goes around comes around.
Yeah, give it long enough.
If you look at the original ACLS guidelines from 1974, bicarb was the first drug.
Yep, and not just a little bicarb either.
Yeah.
Interesting. So obviously there's some limitations to this. Maybe what we're measuring here is something that we don't think we're measuring. Certainly it could be there are some agencies that really like using bicarb, some that don't. Maybe there's a difference in those systems.
Absolutely.
Maybe a marker for something else. Where do you think this goes from here?
Well, ideally, we would have a prospective, double-blind, randomized controlled trial where some patients get bicarb, some get saline, and then do the rest of everything you normally do.
So, I grew up, my first ACLS class was right after they switched from early bicarb.
Yeah.
I grew up with the assumption that it didn't work. You probably know the evidence on it better than I do. Are there RCTs, saline versus placebo?
There are not, but if you want to look at a really good paper from the early 90s, the Brain Resuscitation Clinical Trial, BRCT3, there was a paper that was published with retrospectively looking at the data. The first author is Gad Bar Joseph. I can give you the reference.
Okay.
And what he showed was they actually categorized systems by whether they gave bicarb often and early.
Okay.
So it was often and early or not often and late. Okay. And it showed profound improvement in both survival and neurologic outcomes. So.
Well, I guess I might have to maybe open my mind just a crack on this issue.
That's why we're here.
See, exactly. Well, perfect. Dr. Menegazzi, thank you so much.
My pleasure, Jeff.
This was great. Thank you.
This has been wonderful. Thanks for asking.
Well, that was great information for Dr. Menegazzi. I really enjoyed our conversation, and I have to say, that was actually the first time I had ever met him. He was so kind. I really appreciated the conversation, and I enjoyed it. Great discussions about elk hunting and some of the early research in cardiac arrest. Great stuff. I actually pulled that paper that I threw up on the screen that he was talking about. Really interesting read. I'm going to have to go in and read it a little more carefully. I really want to thank all of the researchers that took the time to talk to me about their work. And I am so sorry that I wasn't able to get to even more researchers. I hope to do better next year. Guys, please let me know if you like this format, if you want more of this format. Let me know what you like, and please don't forget to subscribe to the podcast, to the YouTube channel, and give us a great rating. I hope y'all have a wonderful day. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.